So it's a combination. Certainly early on, we had a capacity issue, and we were getting a lot of tests that were, I mean, if you think about it, our test positive rate, so our percentage every day that was positive was quite low. It was very low. It was less than 1% for most part. And we were testing all kinds of people. So that was not a good use of the resource. We've now dramatically increased our testing capacity, and we're using all of it up until very recently. And what that has shown us is that in the last couple of days, we've saturated a lot of our high-risk populations, but our percent positive per day has gone up, which means we're testing the right people. We're testing the people who are more likely to have this, where there might be an intervention that we need to do. For example, people who are sick enough to be in hospital, people who are part of a new cluster, and I talked yesterday about a community outbreak in the interior, people who are part of something that's an indicator of an outbreak, and those are the people that we're testing now. We're particularly focusing on testing people who are in those environments that are high risk. So we have a testing strategy in the shelter system. We have a testing strategy in our long-term care homes, because we know it makes a huge difference if we detect those places early. So that part of it is directly focused, and we want to make sure we have the capacity for that. It's still, we still would not be testing everybody who has very mild illness for a variety of reasons, not only because of capacity, because it's a waste of resources for a lot of people, but also because we know this test is not 100%. And early on, and when people have very mild symptoms, it can be falsely negative. So it doesn't change what we're going to tell people. We need to tell them on a population level, anybody who's sick, if you have, especially if you have a fever and a cough, you need to stay away from others, no matter what, whether you have COVID or anything else. And so it doesn't change that message to people. And when people are coming in from countries where we know they've been exposed to this, it still doesn't change our management of them. They need to know, and we talked about this, they need to know that they're at risk of this, and they need to stay home and isolate themselves so they're not passing it on to anybody else. And that's their obligation right now. So the answer is not simple, and I know it's challenging to say it over and over again, but we do have a strategy that's based on the best use of the test with all of the limitations the test has itself. I will say as well that that's not the only thing we're doing. We're doing what we call surveillance testing. So this is understanding the rates in the community. And we've been doing that from the beginning. I've talked about this before. It's how we picked up some of our first community cases, where we automatically, if somebody has a test for influenza, for RSV, which is another respiratory virus, we automatically test it for COVID as well, and we're still doing that. And we have what we call our Sentinel Physician Influenza Network. And they are a group of physicians around the province who routinely test people who have influenza-like illness, which is a respiratory illness. And from the beginning, we've been using those tests as well to get a sense in our community of whether people who have influenza-like illness have other things or have COVID. So we're still doing those tests as well. And they have occasionally come up positive, and that leads to an investigation in that area. What we need to do now, and what we actually spent a few hours talking about this morning, is developing our strategy going forward that allows us to continue to target where the most important efforts are. So people who are hospitalized, people who are in long-term care, healthcare workers, certain high-risk settings. For example, some of our more remote communities, making sure we have a rapid testing strategy should we have people who become ill in those communities. And looking at expanding our surveillance in the community to get a more detailed sense of where we're seeing transmission in our communities in a broad scale. So kind of a lengthy answer, I'm afraid, but this is what the WHO has been talking about. We talk about containment strategies and then mitigation strategies, and this is a balancing of containment and mitigation, knowing that our testing is not unlimited, and that we need to, particularly some of the supply chains for the testing, things like reagents, are still tenuous around the world. So we need to focus it and do it in the most thoughtful way that we can, that gives us the best information to understand what's happening with the pandemic in our community as we're going forward. So that's the short answer. I will also, the long answer, I will also say that, if we look at our testing per capita and the testing per million people that we're doing in BC, we're still one of the top in the world. We're doing more per capita than many other jurisdictions, and we're up there with South Korea, and Quebec has rapidly ramped up their testing. But so it's not like we're not testing, and it's not like we're just saying, oh, only a few people can do it. It's just our strategy has changed to focusing on where it makes the most difference and where it gives us the most information.